All right, so we had a corticosteroid therapy for patients with community-acquired pneumonia, and I am fighting for the steroid therapy. So obviously, somebody has pneumonia, they're having an infection in their lungs. Your immune system's going to try and fight it off. You're going to have a lot of cytokines, inflammatory response down in the lungs. A lot of times, you can have too much of that. So I would like steroids for everyone with community-acquired pneumonia because it prevents too much of that immune response. So what did this study do? They looked at both kind of like a regular and severe pneumonia. It was a randomized control trial. They looked at 13 different randomized control trials. Sorry, it was a meta-analysis of 13 RCTs. They defined severe pneumonia and the regular pneumonia. Severe pneumonia, they used the pneumonia severity index, the CURB 65, and a variety of other scoring systems. They basically measured people that got corticosteroids versus placebo, and they measured a bunch of different outcomes, including all-cause mortality, mechanical ventilation, ICU admission, development of ARDS, duration of hospitalization, and time to clinical stability. And in all of these outcomes measured, all 6 of them, corticosteroids were more favorable for all outcomes measured. In all-cause mortality, it had a relative risk reduction of 0.67. In mechanical ventilation, it had a relative risk reduction of 0.45. In ICU admissions, it had a relative risk reduction of 0.69. In ARDS, or to not develop ARDS, it had a relative risk reduction of 0.24. In the duration of hospitalization, people who took steroids had a decrease of about one day. And then time to clinical stability, which they basically defined as having normal vital signs and not needing any oxygen requirement. People that got corticosteroids had a decrease by 1.2 days. So in all the outcomes measured, corticosteroids were beneficial. So basically, I think that we should be giving corticosteroids for everybody with community-acquired pneumonia.
Next up, we've got the rebuttal of why Parker's talking a bunch of nonsense, and we shouldn't be using this yet.
I disagree with Parker. I don't think we should be using corticosteroids for community-acquired pneumonia. So there was already a meta-analysis done by Cochrane, and the only difference is 2 studies that came out in 2015, and the Cochrane review showed no benefit. So it comes down to the 2 studies, which I'll get to later. So when we get to the whole idea of a meta-analysis, you're comparing similar things. And I don't think that this was necessarily a good group of data to use as a meta-analysis. So I think potentially a systematic review would have been better. So the things that they measured: mortality, mechanical ventilation, ICU stay, development of ARDS, duration of hospitalization, and time to clinical stability. Only the last 2, duration of hospitalization and time to clinical stability, actually had a sample size large enough to be clinically significant or relevant, or large enough to determine whether it was useful or not. And the duration to hospitalization, they had high heterogeneity within the studies. So again, it brings the data into question. And I personally would question whether those matter to us in the emergency department, or mortality or mechanical ventilation are more important. So mortality, there was a small benefit for severe pneumonia. Severe pneumonia had multiple definitions. The study from 2015, they defined it as a CRP greater than 150, which I don't know if anyone here gets CRPs on their pneumonia patients. I just don't think we're going to do it in the emergency department. And so adverse events were defined as hyperglycemia requiring treatment, GI bleed, neuropsychiatric conditions, or rehospitalization. These studies don't measure drug safety. So I question whether the sample size was large enough to pick up adverse events.
Just to interject a little bit, so Bree dropped the bomb of heterogeneity. Does anyone know what that is? So basically, a meta-analysis, garbage in, garbage out. You have to make sure that the things that are happening are consistent enough. If you had 15 studies that were all done exactly the same way, then it was very easy to pull them all together. You can add them up, basically, and you're good to go. But in reality, there's differences between studies. How sick are the people? How exactly did they do it? Were they done in similar ways? And so you can actually have data that splays out a little bit, where some things due to randomness and some things due to actual study design are different, okay? Because of that, you can have increased heterogeneity, meaning that the data is not all uniform, where everyone that did the same study didn't find exactly the same finding. So Parker.
No, I just want to say only one of these studies were done in America. That's it.
Oh, wow. Doing the Trump argument. Yeah. All right.
So I have a couple things to say about what Bree had to say. One of the things she was talking about the sample sizes. She said was saying the sample sizes were only really large enough in the duration of hospitalization and time to clinical stability. The duration of hospitalization patient population was 1,200 patients. The clinical stability one was 1,100 patients. All the other outcomes measured, ARDS had 945 patients, so that's like a 200 patient difference. The ICU admission was 950. Mechanical ventilation was over 1,000, and the other one was 997. I think those are pretty trivial differences in population size. So I'm going to go ahead and stomp that one down. As far as she says that hospital stay doesn't really matter to us, the length of hospital stay doesn't matter to us in ED. If you go look at our ED tracker board right now, and look at all the bed holds we have and how that affects our ED, I think the length of hospital stay definitely matters. That's something that we definitely want to. We want the people upstairs to be moving patients quicker because we need to be able to get people upstairs quicker. As far as adverse events, the only one that actually had any statistical significance in the study was the hyperglycemia. It did raise it. There was no adverse outcomes besides the hyperglycemia. They were able to control it. The GI hemorrhage, the severe neuropsychiatric complications, the rehospitalization rates, those were all statistically insignificant. So didn't matter.
So your time to rebut the nonsense that Parker just said about America.
About America. So back to my previous statement about, I think, and I think they even said in the paper that most of these studies were done in Europe. Last time I checked, like Egypt and Saudi Arabia and Japan weren't in Europe. So it's nor America. So it's questionable whether the data that was collected is even applicable to our larger population that does have a lot of diabetes and could potentially would have more adverse outcomes to steroids. So when you're looking at sample sizes and rare events, such as ARDS, need for mechanical ventilation after secondary to pneumonia, those are rare events. So you need a larger sample size to determine a clinically relevant outcome. So I do not, even though if you compare the 6 different outcomes, the rare events, the sample sizes still weren't large enough. And that it's the same thing with the adverse events. A GI bleed, that is a rare event. So a GI bleed secondary to steroids would also be a rare event.
So Parker, bring it home for us in just a couple minutes. Tell us why in the emergency department today, if I see someone with pneumonia, I should be considering steroids. Why should I do that?
Real life or in this?
No, like real life. I mean, we're not talking abstract. We're wanting to take this journal article and say, today on shift, we've got a pneumonia patient. Why is it that we should actually use steroids for them?
So in the community-acquired pneumonia in the ED, if I saw someone today, I would look for other things, other risk factors they might have, like if they had COPD or reversible airway disease, asthma, that sort of thing, and a community-acquired pneumonia, then I definitely think they should have a steroid added on. We use steroids on a regular basis for COPD and asthma exacerbations anyways, minus the infection. So obviously we should be using it for the infection too. Because if that's what made them more likely to get the infection in the first place, then.
And Bree, I want you to tell us why this is not ready for prime time. Why should we not be giving steroids to people like this with community-acquired pneumonia in the emergency department?
So it has been long established that there is no established benefit to steroids, and these 2 studies that were added to this meta-analysis don't really change the picture. So given that there's not a significant benefit that can be proven, I don't think it's worth the extra cost to the patient, to society, and to the system to give them steroids.
All right, thank you guys very much. Let's give them a hand. All right, so by applause, we're going to see who won the debate, and then we'll ask you guys what your true opinion is after this, because we forced this on you to defend a side that you may or may not actually believe. So who thinks that Parker won with his argument that we should be using steroids for community-acquired pneumonia? Okay. Okay, I think those were pity claps, but all right. All right. And who thinks Bree is right, that we should not be using steroids routinely for community-acquired pneumonia? All right, Bree, you are the victor. Now, if you guys want to say, like, how do you actually feel? Would you actually want to give steroids?
No.
No? No? All right. So both of them are saying no.